Hello, everybody. This is your voiceover content for increased ICP and stroke. Your readings in Lewis as follows. Chapter 56, increased ICP, and Chapter 57 is stroke. So ICP, what does ICP stand for? We're going to take a look at the dynamics of ICP, and that stands for intracranial pressure. Number one, does your skull move to regulate swelling? So if you think about anywhere else in the body, you get an injury, say a person breaks their femur. And of course, we're going to have swelling immediately, right? Because that's an injury, it's trauma. Our tissue is going to be able to move with that swelling, right? Because it's not compact, it's not enclosed by anything that is hard, like our skull. So in any other injury of our body, we would have the ability to regulate that swelling. There would be a place for that swelling to go. But if we think about our skull's not going to move, okay? So it's going to be very difficult to regulate swelling of the brain, and it gets very, the symptoms of the patient can be very detrimental if we do not regulate the symptoms of swelling of the brain. So there are three volume components within our skull, three essential volume components, and that is brain tissue, blood, and cerebrospinal fluid, also known as CSF. And what can cause increased intracranial pressure? Really any trauma. So if you think about it, head injury. So if a patient falls, if they have a motor vehicle accident, any type of blow to the head, any sort of trauma, even brain tumors. Remember we had our oncology section and we talked about brain tumors and the increased ICP. Bleeding of the brain, so hemorrhaging, if there's an aneurysm rupture, any cerebral infections like a meningitis, and any inflammatory disorders. So a lot of things can predispose a patient to increased ICP. So when we're talking about increased ICP, there is a primary injury and then there's a secondary injury. So primary injury is at the time of the trauma. So it occurs at the initial time of injury. For example, that blunt force trauma, the patient was in a motor vehicle accident, the patient has fallen, they've had a rupture aneurysm. That all results right away. Okay, so that's primary injury. What happens at that time? So that results in some displacement of bruising or damage to those three components that we talked of. So remember, those three components are the brain tissue, the blood, and the cerebrospinal fluid. Secondary injury is what comes from the primary injury. Okay, so what happens after. So we've had that initial trauma, we've had that initial injury, and it can occur hours to days after that initial injury, but the patient can get hypoxic, they can have ischemic episodes, they can develop hypotension, edema, of course, and as we're talking about, is they'll develop increased ICP. So this is what develops after that initial injury, is the secondary injury. And as nurses, we're really managing those secondary injuries, okay? We're not there for that initial time of injury that can happen at home, but once the patient is brought to us, we really need to manage what's going to happen after the fact, okay? What's going to happen because of the fall? What's going to happen because of that ruptured aneurysm? And we need to fix those things and we need to manage those things. So intracranial pressure as it stands. So what this is a hydrostatic force, and it's measured in the brain's cerebrospinal fluid. So we actually measure ICP through the CSF compartment. Again, what three components maintain the balance of ICP? Those would be the blood, the CSF, and the brain tissue. And there's a lot of normal factors that our body does to regulate ICP under normal conditions. So we have arterial pressure, we have venous pressure, intra-abdominal and intrathoracic pressure, the posturing of a patient, temperature, and blood gases, especially when dealing with CO2 levels. And all under normal conditions, that influences ICP. So if one of these things actually becomes off, say our posture becomes off, or we have an increase in intra-abdominal pressure, or our temperature changes dramatically for some reason, that can help influence whether our ICP increases or decreases. So measuring ICP, what is the normal range of intracranial pressure? It should be reading 5 to 15. It's millimeters of mercury. And what sustained pressure would be considered abnormal? That would be 20 millimeters of mercury. We do not want to see an ICP reading a constant level of 20. It means that we do have an elevated ICP. So ICP can be measured in a patient's ventricles, and that is located in the subarachnoid space, the subdural space, epidural space, or even the brain tissue by a pressure transducer. And we're going to take a look at one of those a little bit later. So we're going to talk a little bit about compensation mechanisms. So how does our body adapt, especially if we do have an increase in ICP? It's pretty amazing that our bodies can adapt to volume changes within the skull, and this can happen in 3 different ways to help maintain a normal ICP. And it's really amazing how our bodies know how to do that. Just remember, this is not long term. The body cannot keep up these mechanisms for too long, but at the initial injury and sometime after, our body will try to compensate and regulate the changes in volume in our brain. So as the volume increases and as the volume continues to increase, ICP will of course rise, and eventually decompensation will happen if we do not fix these things. But there are 3 different adaptations that we can talk about. So there's changes in CSF volume. So the CSF volume can be changed by altering the CSF absorption and production, so our body knows how to do that. So it will alter the absorption and production of the CSF fluid. The CSF fluid can also be displaced into the spinal subarachnoid space, so it's kind of a little extra compartment. So think about it as you have a little extra storage in your house. We're going to place a little extra storage in there so we don't have to deal with that swelling right now, or we can help with the swelling, but it's not going to last for long. Also, the body can change intracranial blood volume. So we'll talk about collapse of cerebral veins and dural sinuses. And then there's cerebral vasoconstriction or dilation. So our veins can get larger in diameter, or they can constrict, and that can change the venous outflow. So our body also knows how to do that to help with swelling in our brain. And lastly, there's brain tissue volume changes. So there can be distension of the dura, so that can move out a little bit. And then there's also compression of the brain tissue. So our brain can compress a little bit, which is pretty amazing. So all these things can help a little bit at the time to decrease any swelling of the brain, but it's not going to happen for long. So continued rise in ICP will eventually result in compression and ischemia. So we want to care for that patient, before these things cannot auto-regulate anymore. So I want to talk a little bit about cerebral perfusion pressure, also known as CPP. So it's a pretty important job, and what it does is it delivers blood to the brain. So the job of our CPP is the amount of pressure needed to ensure blood flow to the brain. Very important, okay? So the way we measure CPP is we take a map, and if you remember what a map is this mean arterial pressure, and we get that from our blood pressure. We take that map and we subtract the ICP, and that will give us our CPP. Nowadays, we have invasive monitoring. We have lovely Philips monitors. This is mainly monitored in the ICU, and that Philips monitor will compute the CPP hourly, or however often the nurse wants to set how often they get that level. So that is read through an invasive line. That would be that ventriculostomy we'll talk about in a little bit, that goes into the brain, and it measures the cerebral spinal fluid. So remember, we get the ICP reading from the cerebral spinal fluid. So it would be that type of invasive monitor, and it would compute to the Philips monitor, and it would give us that CPP reading. Okay? Normal CPP range is 60 to 100 millimeters of mercury. So that's where we really want to keep that range. Anything less, 50 or less is not good. It actually results in ischemia and actually brain death. So we really want to keep it 60 and above. So what happens if our CPP decreases? It decreases blood flow to the brain. It's really that simple. So we don't want to make this any harder than it is, but it just decreases that blood flow to the brain, and that's when it would read in the below 60 levels. Our CPP may not always reflect perfusion pressure in all parts of the brain, so sometimes we can't think of the whole brain. We need to think about local areas of the swelling and compression, so only a certain area of injury, okay? So that's important to think about too, just that perfusion pressure of where the injury may be going is what we need to think about. It may not be the whole part of the brain. Remember in the past slide, we talked about our body's compensation and our autoregulation, and we talked about those 3 mechanisms of autoregulation to help maintain decreased swelling if there is. I want to know what you guys think. Normally, cerebral blood flow and CPP is maintained by what compensation mechanism? That would be the cerebral blood vessels, and we talked about them dilating and constricting. So if our body knows that we have a little bit too much swelling in the brain, our vessels will dilate a little bit. It won't shoot blood up into our brain as quickly. Okay, so that can take off a little bit of pressure to the brain. And if we need a little bit more blood flow to the brain to prevent any ischemia, our body would know to compensate to constrict the vessels to get that blood flow up there a little bit faster to prevent any death to the brain. So any increase in CPP will definitely prevent any tissue damage or ischemia. A good example is actually a patient with an acute stroke, and they may need a higher blood pressure, which in turn that would increase the MAP, right? And then in turn that would increase the CPP. This would then in turn increase perfusion to the brain, and it prevents any tissue damage from forming. So we don't want any ischemia going on. So that's why the doctors are, they really want to know the CPP levels, because if they need to regulate the patient's blood pressure to change the CPP level, then they need to do so. So if the patient needs to get a little bit of an increase in blood pressure, we know that they want their CPP elevated to get more blood flow to the brain. If we need to decrease the blood pressure for any reason, we know the CPP needs to be lowered a little bit, and we'll have to get some antihypertensives on board. So again, this is all done through invasive monitoring. So now we're going to get to the little more interesting stuff here. We're going to talk about increased ICP, okay, increased intracranial pressure. And again, that's from some sort of trauma, some sort of injury to our brain, and it's causing swelling. So we're having an overabundance of CSF in our brain. It's very life-threatening. It results from any increase of those 3 components we talked about, so our brain tissue, our blood, or CSF. So if it's like a hemorrhagic stroke, we have increased blood in the brain. If we have an injury to our brain and it's injured our brain tissue, that will cause swelling or increase in CSF for some reason. So if intracranial pressure is increased, what do you think will decrease? What did we just talk about? Our CPP will definitely decrease if our ICP is increased. So think compression. If there's an increase in ICP, there's most definitely cerebral edema going on. And if the cerebral blood vessels are getting compressed by that cerebral edema, how will the cerebral perfusion pressure be? Not good, okay? So if there's compression going on, we're not going to get as much blood flow as we want to the brain. This can lead to ischemia. Okay, so think about it even like a heart attack. So we have a huge blockage in the heart. It's very similar to the concept of an MI. So we have a huge blockage in the heart. We're not getting as much blood flow to the heart, and that's going to cause ischemia, right? Death to the muscle of the heart. So it's the same concept of our brain. If we have constriction because we have increased pressure in the brain, if we have increased edema and it's constricting the blood vessels, we're going to have decreased CPP and we're going to have some death to the tissue of our brain as well. So ischemia, infarction, it definitely leads to a poor prognosis. So that's why it's so detrimental. If it's left untreated, we'll have brainstem compression, and which leads to herniation of the brain. So the brain swells so much, it has nowhere to go. And the brain can actually, if you remember the foramen magnum, which actually is the opening to where your neck would be, the brain herniates down into the foramen magnum. Just nowhere for the tissue to go in the brain. So that's really the detrimental part of this if left untreated. Also, there may be a midline shift. Remember, we talked a little bit about this with oncology. Remember, we talked about if there was a brain tumor on one hemisphere of the brain, it would push over that brain hemisphere into the other, which is causing that midline shift. But what's worse is that herniation, which is really detrimental and leads to brain death. So does increased ICP affect ventilation or perfusion? Remember, it seems way back in ARDS, but kind of just what we did with ARDS and respiratory failure. We talked about that VQ mismatch, ventilation meaning the mechanical, Q meaning the quality or perfusion, and more oxygenation. So think about it. Think about the causes. Remember, we talked about the causes of ventilation failure, and we talked about the causes of perfusion failure. So the cerebral insults that we have just mentioned in the past few slides, they have a huge impact on ventilation. Okay. So the patient, whenever we have some sort of traumatic brain injury, or it can even be a spinal cord injury or swelling of the brain, increased ICP, it affects our ventilation. Okay, more than perfusion. Okay, so the patient becomes hypercapnic because we're hypoventilating, right? So because of the injury to our brain or spinal cord or anything neurologically, we always tend to hypoventilate. That's just that mechanism that happens. A lot of it comes from our brainstem. Our brainstem controls a lot of our respirations and our respiratory drive. And when we have an injury to our brain, and especially our brainstem, we're going to have depression of our respiratory drive, leading to hypoventilation, leading to hypercapnia, meaning we're going to hold on to CO2. We're not blowing enough off. So another question, are we going to become more alkalotic or acidotic at this point? For sure, acidotic. Perfect. So this was just a cool little slide just to show you kind of like in a nutshell, step by step, what happens when we have increased ICP. So insult to brain, okay, and we talked about a lot of these insults. So it could be a traumatic brain injury. Is it a contusion? Did we have some sort of hemorrhage? Do we have a cerebral infection like a meningitis or an encephalitis? Do we have any masses or lesions that are causing increase in intracranial pressure? Any brain abscesses, tumors, hematomas, even lead or arsenic intoxication can cause swelling of the brain. Okay, so we have our insult. It leads to tissue edema. Here's our swelling. Our skull has nowhere to go. Our swelling has nowhere to go. Our skull does not move. So in turn, we have increased intracranial pressure. That increased swelling causes compression of our blood vessels and our ventricles, okay? So that's going to cause that decreased cerebral blood flow, and our CPP is going to decrease, and that could possibly lead to ischemia, decreased oxygen to our tissues, and probably cell death, okay? So there's 3 different types of cerebral edema, which we're going to go over quickly. The first one we're going to talk about is vasogenic cerebral edema. Okay, this is the most common type of cerebral edema. This edema occurs mainly in the white matter of the brain, and this is from leakage of molecules from capillaries into the extracellular cellular space. So think about it, it's kind of a lot like we talked about with burns. We talked a lot about this with shock. We spent a lot of time this semester talking about leaky capillaries, right? And that happens with inflammation. Remember, any inflammatory process, such as some type of shock, or we have some type of injury like a burn, we're going to develop those leaky capillaries, meaning our fluid is going to shift from intravascular to extracellular, okay, causing third spacing, and this is what's happening in our brain. So just like that same thought of the leaky capillaries with vasogenic, okay? This can occur due to brain tumors, brain abscesses, ingested toxins that can most certainly increase the permeability of the blood-brain barrier, leading to edema. Edema is is of course influenced by blood pressure. It could be the site of the brain injury and the extent of the blood-brain barrier defects. Patients typically will have a headache with this type of edema, decrease in level of consciousness, or it could be more on the severe side of a coma, and then they'll have focal neurological deficits. We're going to talk about signs and symptoms of increased ICP altogether, which I would want you to focus more on anyway. And then we're going to go over the other 2 types in the next slide. But just remember too, a patient can have more than one. It's just not vasogenic. They can have 2 types of cerebral edema, or they can have all 3. Okay. The next type of cerebral edema is cytotoxic, and this is disruption in the integrity of the cell membranes, destruction of lesions or trauma to the brain tissue, results in cerebral hypoxia, and also a syndrome of inappropriate antidiuretic hormone. The blood-brain barrier does stay intact with the cytotoxic cerebral edema, and this occurs from fluid and protein shifts from extracellular directly into the cells. So that's what causes the swelling in this type of edema. And then the last one is the interstitial. So this is a result of hydrocephalus, so it's buildup of fluid in the brain. It is manifested by ventricular enlargement. So this is from excess CSF production, obstruction of flow, or inability to reabsorb. So important things for us to know as nurses, right? So we're going to start off with signs and symptoms of increased ICP. The most important, okay, change in level of consciousness. So that is our red flag here. So this is our most reliable indicator of the patient's neurological status. If we were caring for a neuro patient and all of a sudden we see an increased change in level of consciousness, or more of a change in orientation, or the patient is becoming more somnolent, we really need to hone in on that, okay, and do a little bit better assessment and probably let the doctor know. So again, change in level of consciousness is our most reliable indicator of the patient's neurological status, kind of similar to what we talked about with respiratory too, right? So our cerebral perfusion in our brain is very, very sensitive to decreased oxygenation. So this is why this is always kind of like a number 1 change in really anything. So think about it. We have impaired cerebral blood flow due to the swelling of our brain. It's compressing on our vessels, which leads to oxygen deprivation. Okay. Our changes in level of consciousness, depends on how bad the injury is, how bad the swelling is in the brain. It can be subtle to dramatic. The patient can have, some flattening affect. They can be confused, agitated, restless, change in orientation, or it can even go to more severe symptoms such as a coma. So even in the deepest state of unconsciousness, we need to think about these things. Okay, what's going on with our patient? The patient can lose their reflexes in their extremities. Okay, so if we were to test their reflexes, they may not have them. Are they responding to painful stimuli? If they're in the deepest state of a coma or an unconsciousness, they may not respond to that painful stimuli. Do they have any pupillary reflexes? Okay, how's their gag reflex? Can they swallow? Do they have a gag reflex? It may be absent, and they would lose, continence of bowel and bladder. We were back to that painful stimuli. We hope to get some sort of motor response from the patient. They can hopefully localize the site where they had the pain, either like pressing really hard down on the patient's nail beds, can sometimes elicit a painful stimuli. Hopefully they would withdraw a little bit. The patient may have changes in vital signs, especially if we're starting to have more of that brainstem compression going on. So we're going to have what's called a Cushing's triad. So the patient is going to present with a systolic hypertension, and we're going to have a widening pulse pressure, meaning that we're going to have a systolic pressure and we're going to have a diastolic pressure really far off from that systolic. So an example, we may have 200 over 40. Okay, so that's a widened pulse pressure. There's a huge difference between systolic and diastolic. The patient is also going to present as bradycardic, but if you're going to palpate their pulse, it's going to feel such as bounding. Respirations are going to be irregular. Sometimes, typically these patients present more as like that Shane Stokes Kussmaul breathing. Kind of that irregular respirations. This is a huge medical emergency. And again, this is, the start of like brainstem compression, especially if we get into these changes in vital signs. So signs and symptoms continued for increased ICP. We're going to have ocular signs. So, if you're a nurse and you have a neurological patient, we always want to look at those pupils, right? So what's going to happen is we'll have dilation of the pupil, and it's usually on the same side of the injury. So same side of the swelling that's going on. So if there's like a mass in the brain or the contusion to that one side of the brain, we may see that dilation of the pupil on that same side. The patient will be, the pupils will be sluggish. They may not respond to light. They'll have the inability to move the eye upward or at all. And when we see a fixed dilated pupil, that's a neurological emergency, which means brain herniation. Do we remember what cranial nerve is the ocular motor nerve? That would be cranial nerve 3. Then we're going to talk about decrease in motor function. So the patient may develop hemiparesis or hemiplegia. So that will develop on the opposite side of the injury. So think your pupil is on the same side of the injury, your dilated pupil, but for motor, it's going to be on the opposite side of whatever injury happened to the brain or if there's a mass. Does the patient withdraw to painful stimuli? They may or they may not. And then we're going to notice some posturing. So we're going to talk about decorticate posturing, which means there's an interruption of the cerebral cortex. And then decerebrate posturing, which is definitely more serious, and it's a disruption of the midbrain and the brainstem. Okay, so there's compression of the midbrain and brainstem, which is not good. The patient can develop a headache. They can have projectile vomiting. It can be very unexpected. And this is the type of posturing that we may see in a severely detrimental type of neuro case here. So the first one up top is decorticate. There is internal rotation of the wrists and the arms come to the core. Okay, the arms are held in flexion and the legs are really extended, so the toes will be pointed out. Okay, The second one is decerebrate, which is not good at all. We'd rather see our patient decorticate than decerebrate. In decerebrate, the arms are held at the side in extension, not up to the core, but there's still internal rotation of the wrists, and the legs are still held out in flexion. So the only difference with decerebrate is the arms are at the side, held in extension, rather than up to the core. Okay. So major complications of increased ICP that we really don't want going on is that, of course, the inadequate cerebral perfusion. So if we have that compression, we have that edema to the brain, we're going to have the compressed blood flow to the brain. So we're not going to get that good blood flow, and we'll have that decreased cerebral perfusion. There's which is the worst is cerebral brainstem herniation. Not good. Our brain has nowhere else to go, so it's going to fall down into the foramen magnum. And also we talked about that midline shift, where if there's so much swelling on one side of the hemisphere, that one hemisphere of the brain is going to move over to the other. That is not a good sign as well. And this video here that we'll watch is about it'll show you herniation. So we talked a little bit about that midline shift. Again, think of your right and left hemisphere, and we have that fissure that runs through the middle of our brain, and we hope that would be midline, okay, in a normal patient. But if we have more pressure on one side of our brain than the other, it can actually cause a pushing force where that midline, that fissure, is going to push over to the other side. So a good example on this slide is we have a hematoma on the left side of the brain, and it's actually pushing that midline over to the right. Okay. Same thought on this slide. We have pressure going on now on the right side of the brain, and it's pushing that midline over to the left. And here we are again, another example of a midline shift. Again, this one looks like there is a epidural hematoma on the left side, pushing a lot of pressure over onto the right. And it looks like we're also having some herniation here. It is that temporal lobe is sneaking down into more of the foramen magnum. Okay. And more examples of herniation. Our brain stem is herniating through our foramen magnum. Our tonsils, it looks like our brain tonsils are coming down through our foramen magnum as well. And here is a video on a visual, so you can get a good visual on what brain herniation looks like. So diagnostics of intracranial pressure, increased intracranial pressure. That H&P, that neuro assessment is huge, okay? So what we just kind of went through, we want to look at, is the patient alert and oriented? Are they losing consciousness? How is their strength? Can they move their extremities? Are they posturing? How's their pupil reaction? Can they withdraw to pain? Do they have a positive gag? Okay, so we'll go over that in class, and hopefully everyone can add to a neuro assessment that they would do for increased ICP. How are the vital signs? You know, what are we looking for? We talked about that Cushing's triad. That's an emergency. So if we note that there's a systolic hypertension going on, if there's a widening pulse pressure, and the patient's bradycardic with a bounding pulse, that is not good, okay? If their respirations are not regular, we do not want to see that. We want to do ICP measurement, okay? So that's going to be a little bit more of an invasive monitor, but that'll be what we call a ventriculostomy, which is hooked up to our Philips monitor, and that will be measuring the ICP. There's MRI, CT scan, X-ray. We can look at an EEG. Cerebral angiography will note how the blood flow is moving into the brain. And should we do a lumbar puncture if we think there's an increase in ICP? We should not. If there is an increase in ICP suspected, we should not do an LP. Herniation can actually occur from a sudden release of the pressure in the skull from the area above the LP. Okay, so it would be important not to do a lumbar puncture at that time. So the real important stuff, nursing management, why we're learning about this. So the main thing, if we have a neuro patient, that neuro assessment means everything. It depends on when the doctor wants it done. Typically, if you're in the ICU, we'll be doing that every hour. If the patient is maintained on a med-surg floor, maybe a little less. Okay, so what do we assess? We really want to talk about our assessment. So our pupils, are the pupils equal reactive to light and accommodation? Is the patient alert? Are they oriented? Are they somnolent? Can they follow commands? What's their motor strength like? Are they equal in all extremities? Do we have a deficit somewhere? Is there any posturing going on? If the patient cannot move themselves at all, are they having spontaneous movement on their own? Also with the eyes, if they're not opening their eyes, are they spontaneously doing that on their own if they're not following verbal commands? Do they retract to pain? How's the Glasgow Coma Scale? Okay, the GCS. It kind of helps us assess the level of consciousness, right? So if we take a look at this scale here on the right side of the slide, we look at 3 different things. So we look at eye opening. Is the eye opening spontaneous? Is it to speech? Is it to pain? Or are we not getting a response at all? Okay, so we would score the eye opening. How's their verbal response? Are they oriented to place and time, to person? Are they confused? Are they inappropriate? Are they incomprehensible? Are we not verbalizing at all? Okay. And then our motor function. So are they obeying your commands? Can they squeeze your hands? Do they just move to painful stimuli? Do they flex only to painful stimuli? Are they having abnormal posturing? So are they decorticate or are they decerebrate? Is there no response at all? So the scoring is what helps us get that GCS score. Of course, highest score is good. We want a 15. If it's down very low, we do not have good response at all. It's really important to maintain nutrition. And why do we want to do that? Actually, malnutrition and not good nutrition at all can promote continued cerebral edema. So if we provide good nutrition, if we get a little bit of glucose and sugar into the patient, it actually can promote healing and decrease cerebral edema. When a patient has an increase in ICP, it actually increases the body's need for glucose as fuel for metabolism to the injured brain. So we really need to feed patients, and if they are intubated and they're not responsive, we need to get some tube feeding started and get some sugar going to that injured brain. Suctioning. Do we want to do that a lot? Not really. We want to keep that suctioning to a minimum. It increases any pressure or anything that will cause any increased pressure to the patient. We want to minimize. So if we do need to suction the patient, we want to keep that less than 10 seconds in duration, and we want to limit that to at least just 2 passes only. We want to maintain that airway. We want to monitor the ABGs, right? So if we're not getting that good cerebral, blood flow to the brain, remember we talked about we have that decreased oxygen to the brain. That increased swelling actually can cause collapse on the brain stem, and that can lead to airway issues and respiratory depression. So that's why we really need to monitor the airway, monitor the ABGs, because if we see CO2 levels rising, that's not a good thing. So we talked about suctioning, positioning, okay? Do we want to flex the neck at all, or, keep it elevated too high? So we want to avoid any neck flexion or elevation of the head of the bed. We do want to promote a little bit of drainage, but we don't want the bed any higher than 30 degrees. So we don't want that patient really sitting upright. that will kind of increase the ICP a little bit. And it actually will decrease the CPP, so will not get as good blood flow to the brain. So just that 30 degrees for the neuro patients is good. And we don't want to flex that neck forward too far or back too far either. We want that quiet, non-stimulating environment. So if the patient, they may have some confusion, agitation. At times the patient may need restraint use, but we want to be careful with any restraint use. Any swelling of the brain can cause an increased risk for seizures. So we want to maintain seizure precautions. We may need to put seizure pads on the bed. Is there a suction set up for seizure precautions? And we want to prevent, to protect the patient from any injury, so any falls. So again, with continued nursing management, some of this may be repeat, but repeat is good, right? So if they're intubated, if the patient's intubated, suction only as needed. We talked about on the last slide, keeping suctioning to a minimum if we can. Of course, if they do have large amounts of secretions, we can't let them sit there with secretions. But, limiting it to 2 passes of suctioning, no more than 10 seconds per suction. Preventing abdominal distension, taking, pressure off the abdomen. We can do this by either, inserting an NG tube or an OG tube, and decompressing the stomach and getting rid of some gastric contents and hooking them up to suction if needed. And again, we talked about tube feedings and getting the nutrition to the patient as well. Something to consider too, if the patient does end up, if they do have, facial injuries, or fractures or facial fractures, nasal fractures, we would probably want to stay away from an NG tube and go more for the oral or the OG tube. Okay. Keeping that fine line with sedation. Neuro patients need to really be sedated to rest, okay? We don't want them being agitated or restless and increasing their ICP even more. We talked about, decreasing those metabolic demands, right? We talked about the shivering, we talked about agitation, and, sedation would be a very helpful one for controlling any agitation and restlessness, because then therefore that would cause increased ICP. But we also need to assess the patient too, right? So we need to keep that fine line and keep that fine balance. It's always important if we can, decrease the sedation a little bit when we do need to assess the patient to assess their baseline and minimal sedation. It's really important to do so, because sedation can mask a lot of neurological symptoms and they may not respond. But we do need to elicit some response and hopefully get a response. So coming down on that sedation would be important for that, just at the assessment time. Keeping that environment calm, quiet, okay, decreasing any stimuli is best for increased ICP. Again, going back to those metabolic demands, if they do have a temperature, we don't want to, we want to decrease shivering and keep that to a minimum. If the patient's vomiting, administer, anti-nausea medications, seizures, anticonvulsants, everything like that, just to minimize any, vagal responses or stimuli that could increase ICP. Strict INOs is huge. Okay, we want, especially if they're receiving, we haven't gotten to medication yet, but there's medications that work as diuretics to keep the edema off the brain. So monitoring those I's and O's. Keeping that head of the bed elevated just about that 30-degree mark. So 30 to 45 degrees is great for neuro patients, especially with increased ICP. It's very important to keep that head in the midline position, avoiding any neck flexion or extension, or turning the head side to side, in a way that maybe like very quick side to side moves would increase ICP. So very slow position changes, slow head turning, really minimizing head turning at all, keeping the neck and head in a midline position, head elevated 30 to 45 degrees. Raising the head of the bed above that 30 to 45 degree mark can actually increase can decrease cerebral perfusion pressure. So that is something to keep in mind. Also keeping in mind the ventriculostomy. Okay, we're going to talk a little bit more about a ventriculostomy, but when we're changing positions of the bed, we need to make sure that the patient is placed back into the position where they have actually balanced and calibrated the ventriculostomy machine. So on the ventriculostomy device, there is a transducer that needs to always be level with a certain part of the patient's body. And we're going to get to that, but that's called the tragus of the ear. Okay, so that transducer needs to be directly in line with the tragus of the patient's ear. So if we change positions at all or raise the bed or lower the bed more than what it's supposed to be leveled at, that can cause an increase or decrease drainage of CSF more than we would want. So it's very, very important to make sure that we position the patient where the tragus is in line with the transducer, okay? We talked about turning and repositioning slowly and gently and skincare. This is just a slide that shows you kind of different pupillary responses that could happen in a patient with increased ICP. Again, a normal neuro assessment with checking pupils, we want the room to be dim so we can see the reaction of the pupils. If it's lit bright, it's not going to give us a good assessment, and our assessment could be off. It wouldn't be able to show a good it wouldn't be true, okay? Our pupillary changes would not be true in a well-lit room. So the top eyeballs here, it's showing pupils are equal and they react normally, okay? When we do take our pen light and we have the dimly lit room, when we shine our pen light over the pupil, our pupil is supposed to constrict. And then when we take that light away, we're supposed to see a quick dilation again, okay? So that's a normal pupillary response. Some pupils react slowly. So the pupil on the right is showing that you have a brisk pupillary response. The pupil on the left is showing more of a sluggish response, okay? We can have a dilated pupil, which isn't good. So we have meaning we have a lot of compression on our cranial nerve 3. So that pupil on the right-hand side is showing a dilated pupil. The pupil on the left is normal. The next set of eyeballs is showing both pupils are pretty much fixed and dilated, and that's more of ominous sign, meaning brainstem compression and possible herniation. And then we have more pinpoint pupils here, an example of that. So we have more assessments that we can do to assess for any neurological demise or, neurological dysfunction. So we have an oculocephalic reflex, also known as the doll's eyes assessment. So what we would do is we would take the patient's head, and these are assessments only for patients who are unconscious, okay? So in the unconscious patient, we're going to hold the head, and we're going to turn the head to the right and to the left, okay? Again, I do know we need to minimize our turning of the head for increased ICP, but, sometimes providers do want these tests done, and it's something that we may have to do. We're going to hold the eyelids open because the patient won't be able to do so if they are unconscious, because we need to see the eye reaction, okay? So in a normal patient that doesn't have any neurological dysfunction, we would take the head of the patient and we would move the head to the right, and we should see the eyes actually move to the left. So the eyes are going to turn the opposite way of the head. So if our head is turned to the right, our pupils and eyes should be looking towards the left. And the opposite, if we move our head to the left, our pupils and eyes should be turning to the right. So that would be a normal and good response. If an abnormal response is that if we are going to turn the patient's head to the right, the eyes will follow. So the eyes aren't going to turn the other way midline. And if we turn the head to the left, the eyes are going to follow to the left. And that's where that doll's eyes come in. They just follow wherever the head goes, okay? They do not move in the opposite manner of what we would want to see. Kind of the same thing if we were to flex and extend the neck, we would hopefully see the eyes move down when we place the head upward, and then we would want to see the eyes move up when we would place the head downward, okay? Again, keep in mind any patients who have more of a cervical spine injury, we probably would not want to be doing this. And then there's the oculovestibular reflex, also known as the cold caloric reflex. So the head of the bed should be elevated, and we would take actually a syringe of ice cold water, and it would be instilled into the external auditory ear canal. We'd probably, hopefully assess and wait for about a minute, and then we would want to see eye movement, okay? Some sort of extraocular eye movement, movement of eyes moving around. If we have total absence of eye movement, we know we have something severe going on in our brain. So a positive is that we would want to see eye movement with the cold water installation. If we don't see any eye movement at all, that's definitely severe neurological demise. So a little bit of drug therapy for increased ICP. We're going to talk about mannitol or osmotrol. So this is actually a diuretic for the brain. That's kind of what I call it. Like Lasix is kind of for our body. This is for the brain. So it's an osmotic diuretic, which can decrease ICP. It is given IV piggyback or it can be given IV push. And the osmotic effect leads to plasma expansion. So what happens is the plasma expansion actually decreases the viscosity of the cerebral blood flow, which makes it less thick. So it thins it out a little bit, which in turn would make that cerebral blood flow come to the brain a little bit quicker, right? So if it's thicker, it's not going to get to the brain as quick. But if it's a little bit thinner, it'll come to the brain a little bit quicker, which in turn brings more oxygen to our brain. Very important to monitor fluid and electrolyte status, just very similar like Lasix. We would do the same thing for that as well. Also hypertonic saline solution. It produces massive movement of water out of the edematous swollen brain cells and it brings it into the blood vessels. It reduces swelling and improves cerebral blood flow because of course it's not causing as much constriction and the swelling goes down. So that's going to increase our blood flow to the brain. So we want to monitor blood pressure and sodium levels if the patient is getting a hypertonic saline solution. And then corticosteroids can be used as well. But if a patient has had a traumatic brain injury, steroids are not recommended. So here is our device that actually measures ICP, and this is the invasive monitoring. So it can actually measure and drain ICP. It's all dependent on what the doctor wants to do and what's going on with the patient. If they're having an overproduction of CSF fluid, then that can drain the CSF. This little video just goes over, this little monitor here. So this is a ventriculostomy, and once this ventriculostomy is inserted and hooked up to the transducer, it actually connects to our Philips monitors and it measures the waveform of the ICP. Typically in the ICU, we measure this every hour, and the doctor will actually set parameters on where they want the ICP levels to be at. And I know this looks very confusing and I don't expect you guys to know this, but there's the blue numbers and there's the green numbers here, okay? And that's pretty much the level of where we would set the ICP, okay? So this barrette here, the CSF fluid will drain into this measurement and then in turn it will drain into the bag, okay? That's below. So this ruler type of looking thing on this ventriculostomy is the number that the neurologist or the neurosurgeon will set for the ICP. I just want you guys to get a little bit of an idea about this. I don't expect you to know this, okay? But I just want you to see the visual of what this ventriculostomy looks like. If the levels of ICP increase above the parameters that the doctor has set, the CSF fluid will actually drain out into this burette, okay? And then the stopcock, you'll release the stopcock here at the bottom of the burette, and then the CSF fluid can drain into the bag. This is just another example of the ventriculostomy. So, from patient to device, as you can see, the catheter is placed into the ventricle of the brain, and that's where CSF is produced. So it's going to pick up that good reading of ICP from the CSF fluid, okay? And that catheter goes all the way. As you can see, there's a transducer, which we're going to talk about in a second, which is very important. And then the catheter moves up from the transducer into that burette cylinder. And then the burette cylinder is attached via a stopcock to a drainage bag, okay? So first off, we're looking at the device again. As you can see, there's a ruler measurement. There's blue numbers and then there's green numbers. So there's millimeters of mercury and then there's centimeters of water. So the provider, the neurologist, or the surgeon, that's his job to set it at a number that he wants per millimeters of mercury and centimeters of water. That is not our decision to make. So that's the neurologist. So they set that at a level of how much CSF they want taken off the brain. That's what they're going to set it to. The most important part for us as nurses, as you can see where that transducer is, it's labeled here. That should be in line again with the tragus of our ear. That always needs to be leveled with the tragus. And that is going to be precise measurements of how much CSF fluid is going to be taken off the brain. If that transducer is moved away, above the tragus or below the tragus, it's going to affect the CSF movement out from the brain, okay? It might be more than we want taken off. It might be less than what we want if it's not in line with the tragus. So that CSF is, when that comes off of the brain, it's emptied into that cylinder, the burette. And again, that's due to what it's set at, and that's by the provider. And then every hour we're going to measure the CSF outtake from the cylinder, and that's going to go into the drainage bag by that stopcock. Okay? And here is another example of a ventriculostomy and a nurse leveling out that transducer to the tragus of the patient's ear. There's a different type of level that comes with different companies. This is probably the newest one that we have here at BMC. This looks like the newest company that we have right now, because we've been using these green levels. So you're going to, just like a carpenter would, you would, make sure that level is right in the middle, in line with the tragus, and that level just stays connected to the ventriculostomy. We should be making sure that that's level, at least every hour and at least after every position change that we've done with the patient. As you can see, the CSF it's always got that pinkish hue to it, and it empties into that top cylinder there, as you can see. And then every hour we measure that and empty it into the drainage bag. So we have come to an end of increased ICP. I hope you guys found that a little bit interesting. I know I do. We're going to talk now about stroke. Okay, so there's two types of strokes out there. There's ischemic and hemorrhagic. And ischemic is an inadequate blood flow to the brain, meaning more of brain death. We think about it like we talked about, the same thing as an MI. We're not getting the adequate blood flow to the heart, which in turn causes ischemia and decreased oxygen. The same thing happens with that ischemic stroke. We have that decrease of blood flow to the brain, which the patient will have an infarct. And then there's hemorrhagic, so that's bleeding into the brain, okay? So that can be from a ruptured aneurysm. A lot of times the patient's blood pressures get too high that they have a hemorrhagic stroke. 7 million people over the age of 20 in the U.S. have had a stroke, so that's a lot. And it's actually the 5th most common cause of death and the leading cause of long-term disability in the U.S. So reasons behind a stroke. Why do strokes happen? So the brain is actually normally protected from changes in mean systemic arterial blood pressure over a range from 50 to 150 millimeters of mercury. This is actually called cerebral autoregulation, and we talked about that with ICP as well. So remember, our cerebral blood vessels, they constrict and they dilate, and they change depending on what kind of pressure is going on with the brain. And our bodies always know to keep that blood flow constant to the brain, and that's why the autoregulation happens. It's pretty amazing. So any changes in diameter of the cerebral blood vessels are in response to what the brain needs. So remember, if we're having too much pressure in the brain, our vessels will dilate. It won't send as much blood up to the brain. If we're having not enough, our vessels will constrict and it'll shoot more blood up to our brain. Okay. So when cerebral ischemia occurs, autoregulation may be impaired. So these three things below are all factors that affect cerebral blood flow. So systemic blood pressure, our cardiac output, and our blood viscosity, okay? So if you think about it, any decreases in any of those three will have our cerebral blood flow will be impaired, okay? So it'll be decreased. If we're not getting enough blood pressure, if our systemic blood pressure is low, we're not going to get enough cerebral blood flow to the brain. If our cardiac output is low, same thing, we're not going to get enough cerebral blood flow to the brain. And same thing with blood viscosity, okay? Also, we talked about collateral circulation a while back. So remember, we were talking about like peripheral vascular disease, coronary artery disease, and the patient has blockages, but our body actually gets used to the decreased blood flow, right? Because of the blockage. Same thing kind of happens. Our body compensates for that decrease in cerebral blood flow, and that is called collateral circulation. Our brain needs that continuous blood flow to supply, supply and provide oxygen to our brain, and also we need that glucose to actually maintain our neurons and the function of our brain. We want that blood coming into our brain to at least be sustained at 750 to 1,000 milliliters a minute, and that's actually 20% of our cardiac output. So if blood flow is actually totally interrupted, so if a patient does have a cardiac arrest, cell death can actually occur in 5 minutes. That's how quick cell death can occur, brain death can occur if we don't get that appropriate amount of oxygen and glucose needed to our brain. So this will look familiar to you as well, and we did talk about this when we talked about coronary artery disease and peripheral vascular disease. Are those risk factors? So remember age, ethnicity, race, family, history, and heredity. Can we change those? We cannot. So that will be known as non-modifiable risk factors. But then we talk about hypertension, heart disease, smoking, obesity, sleep apnea, lack of exercise, poor diet, drug and alcohol abuse. These are all examples of modifiable, so we can change those, okay, and we can fix a lot of those things to make a patient healthier. Remember that goal blood pressure is at least a systolic below 140. So before we get into an actual infarct, I want to talk a little bit about a TIA, or a transient ischemic attack. And I think a lot of you, I'm sure, have heard of this before. And this is a transient episode of a neurological dysfunction, which is caused by a little bit of ischemia. So for whatever reason, we didn't get enough blood flow to the brain, and we got a little bit of decrease of oxygen and glucose. So we had a little bit of a blockage for some reason, or constriction, and it caused a TIA. There's actual no acute infarction to the brain, and this is a major warning sign of a CVA about to happen, okay? So if a patient has had a TIA, we really need to do some education. We really need to set this patient up with some help to get a little bit healthier. Maybe we need to control their blood pressure a little bit better. Maybe they have a blockage that we need to fix so the patient does not have a CVA. This should be treated as a medical emergency since this is a major warning sign of a stroke. Symptoms really don't last any more than an hour. Okay, but during that, the patient could have had a little bit of a deficit and it got better quickly. Due to microemboli that temporarily block the blood flow, that's usually the reasons for a TIA. The patient can develop temporary loss of vision in one eye typically. They can have a numbness or loss of sensation in any extremity or fingers or toes. A sudden inability to speak, which can be very scary, so they can develop an aphasia. They can have ringing in the ears, develop a very dizzy sensation such as vertigo, and have transient hemiparesis. So they can have a paralysis in a certain limb or a certain side. Okay, and again, it doesn't last more than an hour typically. But if patients experience these symptoms, it should be educated, especially if they're at home, that they need to go to the ED immediately. Even if they did get better, we should really educate patients to go in anyway, because it actually, it may be a start of a stroke occurring, and not a TIA. So they need to go either way. So ischemic stroke, ischemia means no oxygen, right? So it's inadequate blood flow to the brain from a partial complete occlusion of an artery, okay? Typically, we see this a lot in the carotid arteries. Two different kinds of ischemic strokes. There's thrombotic versus embolic. So talking about the thrombotic ischemic stroke, it's actually an injury to a blood vessel wall and formation of a blood clot. Okay, the lumen of the blood vessel becomes very narrow and occluded because of the clot. This is the most common cause of stroke. It happens in about 60% of patients. And this is typically from atherosclerosis. And again, talking about that collateral circulation, it can develop, especially if that clot, isn't big enough to totally occlude the artery. We'll have a little bit of blood flow going through, but not what we normally like. Collateral circulation will develop. But if that gets totally occluded, that's a definite issue, and we're probably definitely going to have an infarct. And then there's embolic. So this occurs when actually the clot becomes free-flowing. So it's not just lodged somewhere in the vessel and occludes. The clot becomes actually free-flowing, and it lodges and occludes an artery. So this is actually the second most common cause of a stroke. Most emboli originate in the inner part of the heart, and I'm sure you guys can guess what causes that. So remember our heart rhythms. What condition you think causes embolic stroke? That would be atrial fibrillation. Yes, we have that clots form within the heart because we don't have that constant blood flow. We have pooling of blood in the heart, so that will cause AFib and actually lead to an embolic stroke. So the clot breaks off and enters the body circulation. Embolic strokes occur rapidly, and it actually gives little time to develop any collateral circulation. So if you look at the difference with a thrombotic ischemic stroke, it actually gives some time to develop a collateral circulation, so we don't always have that totally occluded artery. It's narrowed, so we do have a little bit of blood flow going through, which collateral circulation develops. But with an embolic stroke, it totally lodges the artery, and it occurs very rapidly. So if you just take a look at the two differences here, there's a thrombotic stroke and then there's an embolic stroke, and it's showing you the difference of the clot. So in a thrombotic stroke, you can see the plaque, which is more like an atherosclerosis looking type of clot. So the process of clot formation results in a narrowing of the lumen, which blocks the passageway of blood through the artery. And then the embolic stroke, this was, remember, free-flowing, and it has lodged itself, so there's no blood flow to the brain where it has lodged. So now we're going to talk about hemorrhagic stroke. So this is an intracerebral hemorrhage, and this is actually bleeding into the brain caused by a rupture of a blood vessel. That's very poor prognosis. There's a 40 to 80% mortality rate. And like I had said before, hypertension is really the most common cause of an intracerebral hemorrhage. The blood pressure gets so high it actually ruptures a vessel in the brain. The patient will definitely have neurodeficits. They can develop a headache, acute onset of nausea, vomiting, slurred speech, weakness to one side. You'll note deviation of the eyes, a definite decrease in level of consciousness, and the patient will maintain in a hypertensive state. If there is progression of bleeding, you'll note that there is fixed dilated pupils, definitely abnormal posturing like we have talked about before, and increased ICP, and possibly leading to a coma. So the other type of hemorrhagic stroke is a subarachnoid hemorrhage, and this is intracranial bleeding into the cerebral spinal fluid-filled space, and this is actually a rupture of a cerebral aneurysm. This is known as a silent killer. It really does not have any warning signs or symptoms, until the rupture has occurred. So it's very immediate. The patient will have changes in level of consciousness, cranial nerve deficits. They can develop acute nausea, vomiting, seizures, and a stiff neck. With a subarachnoid hemorrhage, there is poor prognosis, and most patients die immediately after rupture of an aneurysm. Survivors are typically left, ventilator dependent if that was a choice of the family, with significant cognitive problems. So clinical manifestations of a stroke, what happens? So there's definitely motor deficits, okay? So the patient will have a loss of voluntary movements, typically, impaired integration of movements, poor coordination. They will have changes in muscle tone and reflexes. There could be paralysis, normally on one side, or flaccidness or weakness, depending on the extent of the deficit. Loss of sensation, and this is definitely what we call contralateral. So as you can see in this picture on the right, if there's a deficit or infarct to the right side of the brain, the left side of the body will be affected, and just opposite. The left side of the brain infarcted, you'll have a deficit on the right side of the body. Typically, if there is an infarct on the right brain, we'll see paralysis to the left side or hemiplegia, left-sided neglect, spatial or perceptual deficits.
Look who decided to join us. Look who's here.
So clinical manifestations of a stroke, we're going to start off with motor deficits. So the patient may develop loss of skilled voluntary movements, or impaired integration of movements, or even poor coordination. Changes in muscle tone and reflexes. The patient can develop paralysis, flaccidness, and weakness, especially depending on what side of the infarct of the brain it's on. Loss of sensation, and these motor deficits are contralateral. So if there is a right brain infarct, we'll have issues on the left side of the body. Or if there's a left brain infarct, we'll have issues on the right side of the body. So it's the opposite side of where the infarct is on the brain. So if you take a look at the image on the right, if there is a right brain infarct, the patient can develop paralysis on the left side or hemiplegia, left-sided neglect. They tend to have spatial or perceptual deficits. They tend to deny or minimize their problems. Rapid performance, and they have a short attention span. These patients can be very impulsive, which leads to safety issues, impaired judgment, and impaired time concepts. Now, if there's an infarct on the left side of the brain, patients will, of course, have the right-sided hemiplegia. They tend to more have speech issues, so they'll be more aphasic. Impaired right and left discrimination. They'll be more slow and cautious. They are aware of their deficits, which can lead them to more depression and anxiety. And they develop impaired comprehension related to language and math. So like we just talked about, the left hemisphere is definitely dominant for language issues. So we're going to talk a little bit about aphasia, dysphagia. So the first one is the Broca's aphasia. This is known as non-fluent aphasia. It takes a lot of effort to say words or string sentences together. And you can tell that by the patient. There's a few videos we're going to look at in a little bit. But you can tell the patient is really trying to think, really working hard to say even a word or string together a few words. They may only be able to say a few words at a time, like 3 or 4 words at a time. They have limited vocabulary and they have trouble finding the words. But their understanding is good. So they understand what you're saying, but sometimes they just cannot find the words. So their intelligence definitely remains intact. The next type of aphasia is global aphasia, and this is another form of non-fluent aphasia. It's the most severe form, so they cannot speak many words and sometimes cannot even understand speech. So they cannot read or write. They have severe communication difficulties. So they're really even not, understanding what you are saying. And then there's the Wernicke's aphasia. So speaking isn't difficult for the patient and words pour out of their mouth with ease, but it's not coherent and it's not making sense. So the person isn't forming coherent words, or those words aren't coming together into coherent sentences. So this is known as fluent aphasia. So we will take a look at these videos in class. So more signs and symptoms of the stroke patient. Their affect can be a little bit exaggerated. They can have a depressed affect, emotional. They can be restless and agitated, especially depending on what side of the brain the infarct is on. Remember, we talked about if it's on the right side, they're a little bit more restless and agitated, or if it's on the left, they're a little bit more emotional and depressed. Definitely impaired memory. They can have impaired judgment, problems with spatial or perception and judgment, incorrect perception of self and illness. They may not recognize own body parts. They have an inability to recognize an object by sight, touch, or hearing. So you may look at a picture and they cannot tell you what's going on in that picture. And they may have issues with incontinence and constipation. So diagnostics for a stroke, CT scan is really important, and a CT angio. So they'll do a CT scan without contrast first, and then a CT angio, which is with contrast, and that really kind of lights up the infarct of the brain when you do it with contrast. MRI, there's perfusion scans, which are a little bit newer, but a great add to the stroke world and the neural world. Carotid angiography, there's carotid duplex scanning. So, they can take a look and see if there's any clots in the carotid arteries. Cerebral angiography, how is the blood flow to the brain? Where is the neglect in the blood flow? Labs, so cardiac markers, troponins, coags are important. What are their lipid levels, CBC, and electrolytes? Getting an ECG is really important, and blood glucose is so important. And why is that? Blood glucose actually can, if the patient is having signs and symptoms of a stroke, we really want to get that blood glucose right away, because hypoglycemia can actually mask symptoms of a stroke. It can show the same exact symptoms of a stroke. So we really want to rule out whether or not the patient is hypoglycemic or not. Okay guys, so here is a picture of a good example of what a perfusion scanning looks like. So in the last slide we talked about diagnostics, and we know that CT scanning without contrast is very important to get right off the bat, right? So your patient comes in from the emergency department and you're going to bring them right to that CT scanning first without contrast, because we need to rule out whether the patient has a bleed or if it's an ischemic stroke, okay? And that can further help us treat the patient with TPA or no TPA. Yes, they will get that CT angio right after they rule out whether it's ischemic or hemorrhagic, and that CTA is just going to show a little bit of a better picture of the infarct in the brain, okay? Especially if it was ischemic. So this is quite new. At least within the past, I want to say 4 to 5 years, we've had perfusion scanning at Berkshire Medical Center. So again, very new. And what this does is it lights up the salvageable part of the brain. and what the provider can save if we're the patient we're going to go to clot retrieval. So the whole point of perfusion scanning is so the patient can have clot retrieval afterwards. This is especially important if patients are not eligible for TPA. Is every person going to be perfusion scanned? Yes, probably most likely that has a stroke, but even more so important for patients who are not eligible for TPA, who are outside of the window of 4.5 hours. Clot retrieval itself can be done up into 24 hours, which is wonderful. So this will help patients have recover from deficits, okay? Just like almost a TPA would. When we retrieve that clot, it's going to, send that blood flow right back to the brain again. So it's almost the same kind of thought as when we talk about STEMI and we have to get the patient to the cath lab to open up their artery to the heart, whatever is occluding their artery. And once we get that blood flow back to the heart, we save that heart muscle again. So very similar thought. It's not as emergent, so don't get too confused. We talk about STEMI, door to balloon time. With that is 90 minutes. Perfusion scanning, we have at least 24 hours to get the patient for clot retrieval. But this is a wonderful diagnostic study. Again, it shows salvageable brain tissue that will be saved once the clot is removed. And that is perfusion scanning. So what do we want to recognize with a stroke? So we've probably heard about that ACT FAST, right? The FAST. So just taking a look at the face first. So do they have weakness or a droop in their face? So if we notice that there's a facial droop, or we want to ask the person to smile to observe their face, we can definitely recognize if one side of their face may appear droopy. The A, the arms. So a stroke can can cause muscle weakness, numbness, and even paralysis, typically on one side, but sometimes it can be on both sides of the body. So we would do our assessment with asking the patient to, can you squeeze my hands? Can you raise your arms? Look for any signs of weakness. Is there a drift in one arm? Is it drifting downward? And then moving on to S, which is speech. We'll often find that the speech of a patient who's had a stroke could be garbled, difficulty speaking, or slurred. And then T is timing. So if we observe any part of the FAS, face, arms, and speech, we want to get this patient to the hospital as quickly as possible. Timing is everything with a stroke. So, we want to educate families to call 911 so we can get that patient to the hospital as quickly as possible. So what is the single most important question we want to ask to treat a stroke? Either family or if the patient can answer. Is their last known while? It means everything. Okay. It guides us in a treatment plan for possible treatment with what is called TPA, okay? So administration of that TPA medication is vital to getting the patient, feeling better as quickly as possible and without deficits, hopefully without deficits. So it's preserving the brain. So this is why it's important is TPA administration. We should give this as quickly as possible. It preserves the brain and it reduces any disability to the best of its extent. So stroke protocol, okay? So patient presents with stroke symptoms. So, say we're on 3 neurocardiac and a patient presents with symptoms of a stroke. They have a facial droop. What do we want to do first? So we want to look at that last known well, right? Okay, hopefully we know that last known well. Or if they're coming in from the ED, hopefully their family knows the last known well, or the patient can tell you when they last felt well. And after that, we're going to talk a little bit about the NIH stroke scale. Okay, so we're going to talk about that in a little bit, but we're going to need to do that. You have to be certified to do the stroke scale, so you have to take a course and become certified in NIH. But once you do that, you can do this test. We want to do vital signs. We want to know the blood pressure. We want to get a glucose. Remember how important glucose is. Hypoglycemia is a major, shows the same exact signs as a stroke. We want to get the weight of the patient, because if they can get that TPA, we need to know the weight, because the pharmacy will need to make that medication specifically for that patient dependent on their weight. If there is time, maybe just get an EKG. We want to know if there is any heart rhythms that may be causing clots that would show ischemia. Get their pharmacological history, okay? Are they on any anticoagulants, okay? Anything that would make them bleed out, especially because TPA, is that clot buster. So we do not want the patient to bleed out if they are on any anticoagulation. Figuring out if the patient is eligible for TPA. If the patient is eligible for TPA, this is when we actually want to page the stroke team, okay? So we want to figure all these things out first, and then we want to page the stroke team when we know that they are eligible. We want to ensure that the patient has 2 large bore saline wells in. Okay, this is really important when the patient goes down to their CT scan. So we want to get that stat head of head CT. So first it's going to be non-contrast. The reason for non-contrast is we want to make sure that we want to rule out if there's a bleed in the brain. Because if there's a bleed in the brain and we give TPA, then we're going to be in even bigger trouble than we are now, because we're going to have a major bleed. So once we rule out that we can give the TPA and there's no brain bleed, we're going to do the CTA, so that's with contrast, and we're going to take a look at the ischemic stroke in the brain. BMC has a fairly new system that calls out to Mass General. It's called our telestroke team. So we actually have one of those computers on wheels. We call the telestroke Mass General, and a doctor actually appears on the screen of the computer, and we'll do the NIH stroke scale in front of that doctor on the computer, and he actually kind of tells us what to do from there, okay? What kind of treatments that the patient should need, what kind of stroke he thinks this is. He'll look at the imaging of the CT and CTA, and our stroke is pretty much outsourced to MGH. So once the head CT is completed and the bleed is ruled out, we definitely want to call pharmacy to mix that TPA. Pharmacy will bring that actually right to the CT scanning area, and the CCU charge nurse will administer that TPA right in the holding area of the CT scanning room. They also will do that perfusion scan. So if they note that there is a clot that needs to be retrieved and there's going to be a good amount of preserved brain after the clot is removed, then they will transfer the patient out to Albany to do clot retrieval. It's really important to know the last known well. So the last known well to get TPA would be up to 4.5 hours. If the patient is over 4.5 hours, they are considered not eligible for TPA. So we're just going to go over the NIH stroke scale in class. I don't expect you guys to know this, especially because you do need a certification in NIH, but I think it's good just to go through real quickly to see what we test the patient on, their motor deficits, their physical deficits. There's quite a bit to go over with the patient. So caring for a patient with an ischemic stroke. So we want to note the deficit in the patient, and we want to immediately gather that last known well time, okay? Always assess responsiveness in their airway. Circulation, airway, and breathing is always number 1, right? And we want to start that stroke protocol sheet. So kind of everything we went over in the last few slides is what we need to do. So if that patient is TPA eligible, we need to call the stroke team, okay? So we need to do those vital signs, get a good blood pressure, maintain the patient's oxygen. We may need to throw a few liters on the patient, get an EKG if there's time, and also get that important blood glucose level. IV access is important. That CCU charge nurse will come to that stroke protocol, okay, and they're actually responsible for bringing the patient down to CT scanning. And again, the patient's going to get that non-contrast first. We're going to rule out any bleed in the brain, and then we're going to do that CT angio with contrast to take a deeper look into the stroke. So once we know that there's no bleeding, we'll call pharmacy. They'll mix the TPA depending on the patient's weight, and TPA will be administered right in the CT holding area. Do we keep the patient NPO after a stroke? Yes, absolutely. A lot of times strokes will ruin, the patient won't be able to swallow after a stroke. They'll have trouble swallowing, so we need to do a swallow eval before the patient can eat anything. A monitoring of blood pressure is very important. So blood pressure is typically elevated, and it's very common during a time of a stroke. We don't want to bring that blood pressure down too fast because we still need that adequate cerebral perfusion pressure, right, at this time of crisis. So even though we have a high blood pressure, we don't want to bring it down significantly because we still need that blood flow to the brain, and we need that oxygen to the brain. If we do need to bring the blood pressure down a little bit, labetalol and nicardipine are typically the choice for antihypertensives that can be given either IV push or by a drip. Like I mentioned before, they will need a swallow eval post-stroke. Patients cannot eat until a swallow eval is done. Dysphagia is very common post-stroke, so we don't want to risk any aspiration at all for the patient. Typically, we'll see first if they can swallow a spoonful of water, and if they can do that, we do applesauce. So it's just testing their swallow. And again, if you're NIH stroke certified, you do follow up with the swallow eval certification as well. And you'll be able to do that as a nurse if you take that course. We do want to control elevated blood pressure, especially if we are giving TPA, and I'll go into that in a little bit. We want to give some IV fluids for hydration, and of course, as nurses, we want to do those hourly to every 2-hour neuro checks to make sure that we're not getting any new deficits. It's pretty amazing. After TPA is given, you see deficits disappear quite quickly. Once the clot is busted and we're getting blood flow and oxygen back to the brain. So talking about TPA, so it's fibrinolytic therapy, so tissue plasminogen activator, known as TPA. So this medication actually binds to the fibrin in the clot and it breaks it down. Okay, so that's why I call it kind of a clot buster, okay? So it's given by IV drip, it's given by a CCU nurse, and again, what's the time frame for TPA? 4.5 hours, okay? So anything above 4.5 hours, we cannot give TPA. If their last known well is 0 to 4.5 hours, we're good. Blood pressure is pretty important, so we must be below 185 over 110 to give TPA. Labetalol, if the patient is hypertensive above 185 over 110, we can give labetalol to bring down the pressure a little bit before TPA administration. And then the CCU nurse will continue to monitor the vital signs closely and continue to do neuro checks. And like I said before, improvement of deficits happens pretty quickly. We also want to know, like we said before, what's their farm history? Are they on Coumadin? Are they on any anticoagulants? Because if they are, we cannot give TPA. What's their lab values of coags? Did they have any recent GI bleed, any head bleed? And TPA can't be given either with that type of history. This is just a little video on how clot retrieval is performed, so we'll do that in class. So care for a hemorrhagic stroke. So of course no anticoagulants, right? We do not want to give the patient any anticoagulants, and management of the patient's hypertension is really key. Because what is most common for a hemorrhagic stroke is severe hypertension. So we want to slowly bring down the patient's blood pressure. We want to at least maintain a systolic blood pressure less than 160. And because of the bleeding in the brain and the edema that's caused in the brain, we want to just monitor for any seizure activity and provide seizure precautions. So we'll put the pads on the bed. We want to make sure that there's a suction. We want to we'll probably do an immediate evacuation of any hematomas. So we'll get that blood out of the brain. We'll have to do a craniotomy and evacuation. Ventriculostomies, like that image we saw before when we talked about the ICP, that can be inserted. That is to decrease any ICP and decrease the bleeding during a head bleed. So any pressure that we can relieve, a ventriculostomy can be placed. Also, if there is an aneurysm, there is going to be clipping of the neck of the aneurysm to block blood flow. The clip will stay in place for life. And a medication, nimodipine, it's a calcium channel blocker, and that can treat cerebral vasospasms, and that can be cerebral vasospasms can happen during a hemorrhagic stroke. CT scans will be done daily, if not more frequently, to check for the decrease in bleeding, to make sure that the bleeding is decreased. It's a very, very slow process, and patients typically stay in the ICU for large amounts of time. This right here is just an example of what a ruptured aneurysm may look like within the brain, and a surgical clip, it almost is very similar to what a paper clip would look like. It is placed right on the neck of the ruptured aneurysm, so the bleeding, it'll stop the bleeding. Just like a clamp, you're clamping off the bleeding. So post-stroke nursing considerations. So we want to, as a nurse, we want to do continued ongoing neurological assessments, monitor those vital signs, especially looking at that blood pressure, making sure it's within range, looking at the heart rhythm, making sure that they're not having any dysrhythmias. If on a new blood pressure medication, what should we really check before that patient gets up for safety? We want to do orthostats. So any new blood pressure medication can make a patient a little bit dizzy, and we don't want the patient falling. So we want to do the orthostatic vital signs before ambulating the patient. Venous boot utilization is really important, so VTE prophylaxis, range of motion exercises, and physical therapy, especially if the patient does have the motor deficits. We really want to prevent any joint contractures and muscle atrophy. And giving that emotional support, especially if they do have deficits, it's very, very scary for the patient, and especially if they were, say you were a carpenter and they worked a lot with their hands and they have deficits, especially, in one hand or the other, that they can't use anymore, they're paralyzed. That's extremely, the patient can go into an extremely depressed state. So we want to provide that emotional support. Stroke is a big one for quality improvement measures for nationwide for most hospitals across the nation. A lot to do with Joint Commission, of course, and insurance, and very similar to like our sepsis protocols. So a lot of protocols that you see are done for reasons to make sure that we don't miss anything that's going on. But when a patient does have a stroke, these items that are listed below need to be instilled or intervened or have some sort of intervention going on. So a patient needs thromboembolism prophylaxis. So they need venous boots on. Okay, that's pretty much what that means. They need those venous boots on, and Joint Commission and our core measures, CMS, will get marked on that. Is the patient getting discharged on antithrombotic therapy? Of course, if they're eligible for it. Okay, we don't want to cause any further bleeding for the patient, but if definitely that they're eligible, they should be discharged on an antithrombotic. Also anticoagulation therapy for patients who do have, rapid AFib, A-flutter, or new onset AFib, A-flutter, just to cut down on the risk of of clots, especially for embolic strokes, right? That the patient received thrombolytic therapy if they were eligible, right? Did they receive the TPA if they were eligible? And there should be, documented reasons why they did not receive TPA. The patient always should be discharged on a statin medication, like a Lipitor or Zocor. That's very typical for patients that have had strokes. Patients need to receive stroke education of some sort. So, printing out a packet, going over, extensively with the patient and family about stroke education and rehabilitation. And also the patient should be assessed for rehabilitation as well. Nursing considerations continued. So we want to work on that turning and repositioning, especially if the patient has severe motor deficits to one side or the other. We want to prevent skin breakdown. Constipation can be common after a stroke, so we want to administer stool softeners, make sure the patient's taking in fluids, fiber intake. There may even be a possible need for bowel retraining after a stroke. Incontinence care that can be common as well after a stroke, and also retraining for bladder retraining. Swallow evaluation is really important. If the patient does have a swallowing deficit, do they need thickened liquids? Do they need thickened foods? Will they need special utensils? And doing mouth care is really important. Also important, mouth care before feeding can actually help stimulate saliva, and it can help the patient swallow a little bit better. So that's one thing to remember. We want to really prevent aspiration, so providing aspiration precautions, cutting the food up into small bits, using the thickened liquids, not using a straw, drinking from a cup, sitting the patient upright, providing speech therapy for the patient, and communication. What can we do to make communication easier for the patient? So, we want to allow time for the patient to comprehend and answer us. Sometimes it can be very delayed. Can we use visual cues, pictures? What will help the patient the best? So these are just some pictures of what we can help stroke patients, especially if they do have some deficits. To the far right here, this is called a trochanter roll, and it actually prevents external rotation of the hips. To the far left on the other side are called hand cones, and that actually can prevent hand contractures, and these are more recommended over washcloths. There's arm supports with slings, and it can prevent any shoulder displacement, which can be common. And then we have special boots here, which can prevent foot drop, which can also be common in stroke patients. And these are just some utensils to use for patients who have had a stroke to help eating a little bit better. As you can see, the handles on the utensils are a little bit thicker, so it's a little bit easier to grasp. Some of these are turned, so if the patient has a deficit, it cannot get the food onto their fork or spoon, this can help them a little bit more. And a raised bowl can help a lot, especially if they cannot use their other hand to get food onto their utensil. They can press it against the bowl to get it on their utensil a little bit easier. And that is all for increased ICP and stroke. Again, I'm looking forward to seeing you in class on Thursday or tomorrow. And if you have any questions, please feel free to email me. If there's anything that didn't seem like it made sense, I would be happy to make it make sense. So thank you very much.